All right, so I'm going to introduce our panelists. We have three great panelists this afternoon. First, we have Mary Kasal, and she's the president and CEO of the Missouri Health Connection, Missouri State Designated Health Information Organization. Next, we have Bryan Bliven, who is the interim director of the Tiger Institute, which is a collaboration of the University of Missouri and Cerner Corporation, based here in Missouri. And then we have Rachel Muturx, who's the director of the Missouri Telehealth Network. But you all know her as Miss Telemedicine, but she's going to go beyond that and talk a little bit about technology in both health and wellness as well. So we're going to go ahead and kick it off. And Mary, welcome to the podium.
Thanks so much, Karen, and I appreciate being asked to come back this year. Last year I came and for one of the panels, and I didn't know you had to have a presentation first. So I appreciate being able to get another opportunity. I'm excited today to share about Missouri Health Connection and the progress we've made in the past year, and then a little bit of my personal passion around I'll go for micro data versus big data. That is my passion. So where I sit the... So what is Missouri Health Connection? We are the state designated entity charged to create a statewide health information network for Missouri. We're a non-for-profit entity established in 2011. We have a board of directors that is both public and private, and we are founded out of the Health IT Technology for Economic Clinical Health Act, HITECH Act, passed in 2009. Our mission is pretty broad. Improve the quality of medical decision-making and coordination of care, provide accountability and safeguarding privacy and security of medical data, reduce preventable medical errors and avoid duplication of treatment, improve the public health, enhance the affordability and value of health care, and empower Missourians to take a more active role in their own health care. Our values are connecting all health care providers in the state of Missouri. We are the state designated entity to create the health-wide information network for Missouri, and our platforms are called CareNet, CareViewer, and CareMail. Our technology is pretty simple. It's basically a query-based information network that translates clinical data from multiple providers with disparate EMRs into an aggregated clinical summary format and provides clinical information delivered where you need it and when you need it. In our medical record, we have from all participants, medication history, allergies, immunizations, consent management, all of the different things on this screen, and many tools for physicians that practice in rural areas that maybe do not have an EMR, along the lines of referral support, notifications, and consult response messages. Here's a snapshot of our system, and I'm just going to walk through it really quickly. We provide this system across the state, and to all participants, it aggregates across all of our participants and brings that data real time to the physicians in a clinical summary that is standards-based, that looks like a patient chart, that brings documents and clinical repositories together so that a physician can see every lab, and I'm going to go back to that. They can drill down on those lab results. They can see diagnostic imaging data, real time, in a diagnostic quality viewer, medication history, vaccinations, and diagnosis history, past and present, complete encounter history, and interoperability built in. So I'm going to talk a little bit about why this is microdata in my mind. My passion has always been to work for physicians. They have been my mentors my entire career, and they have challenged me personally to deliver them clinical data real time, when they need it to treat their patients. To them, it's not big data. It's as simple as the difference between a 0 and an 8 on a screen. And I'm going to tell you how I first was introduced to that. I think it was about 10 o'clock at night, and I was a CIO in Bakersfield, California. And I got a call from one of our ICU intensivists. He was in the ICU, and he was tearing his hair out because on the screen, he could not tell the font between an 8 and a 0. And he had the passion to call me and say, you have to fix this, because if I read this as an 8, I'll make one clinical decision. If I read this as a 0, I'll make a different clinical decision, and that will affect the life of this patient. Since that time, it has been my passion to present data to physicians in a clinically relevant way so that they can take care of their patients real time, wherever they are. This is a little snapshot of another lightweight tool that we have. It's called Care Viewer, and it really is simply a snapshot of everything we just presented. We also have a tool called CareMail, which is prevalent across the country. This is something that came out of the government funding for our service men and women across the world, and it's basically a secure email platform. So it is a direct secure messaging platform that routes care summaries, clinical lab notes, and results anywhere, anytime a physician may want to do that. Just looks like an email platform. Now I'm going to switch a little bit to some of the overall topics that we've been talking about today, because as my life has been spent in healthcare IT, there's some troubling factors around the spend of healthcare IT in the country. And I want to talk a little bit about it. When I got here last year at Missouri Health Connection, we had no presence on the map. On the side of the screen are now our points of presence across the state. And we are here to serve all of the state of Missouri, to connect all the hospitals in the state with all the physicians, rural clinics, FQHCs, physician offices across the state. That's our mission. But the economic reality is where IT spend is right now is not where we are. It's in hospitals. I'm going to show you a couple of stats. The boom, the spending boom in healthcare throughout the 1980s to about 2009, a little bit before, was the battle of the cranes. Hospitals spent billions of dollars building beautiful towers with private rooms, sophisticated technology to the tune of billions. I happen to have lived in England for a while, and I found the care in a 1600-old facility just as good as the care here in America with these great, fantastic buildings that we've been building. Unfortunately, for my profession, a lot of that healthcare spend has now shifted to IT. This is a $1 billion system that went down about 2 months ago at Sutter Health. When they spend $1 billion on an EMR, I don't think there's a return on investment in our lifetime. And I think as a nation, we need to think about that. So the economic reality is we, Missouri Health Connection, exist as a result of the HITECH Act and ARRIS funding. That was $564 million for the entire country. If you divide that between the states and the territories of the United States, that's roughly $11 million per state to connect all those hospitals that have spent $1 billion on EMRs. There's a little bit of disparity in that picture, and I think that's an important challenge for us coming forward. If we think about what IT is now in healthcare, my deep concern is that it now represents billions of dollars in the healthcare industry. And I think that We haven't really talked about that today. We've talked about the Affordable Care Act and the great mission that that is. But we know that all of our hospitals, many of them, many physician offices, in the last 2 to 3 years had to spend millions, if not billions of dollars, putting in EMRs to chase those meaningful use dollars. I think we need to be aware of those trends and watch for them. Capital spend per bed on IT grew 62% in 1 year. This is not a small problem. According to the World Health Organization, more health care as a percentage of GDP is spent in the United States than any other nation in the first world. The United States ranks 46th among 48 countries included in the study. So spending more and achieving less is not an answer. I think this is a policy question for maybe next year.
Good afternoon. Thanks for the opportunity to speak today. So one thing as the interim executive director for the Tiger Institute, the other hat that I get to wear is the chief information officer for the health system. So I'm going to talk to you a little bit today about how technology is changing healthcare here in mid-Missouri, some of the things that we're doing here in Columbia and throughout mid-Missouri as part of the Tiger Institute. And I'll start actually at the beginning of this century. As I was a few years into my healthcare IT career, this report came out, to Err is Human, from the IOM, and I was reading it thinking, great, boy, did I choose a great career. 100,000 deaths that we can prevent because of what I'm going to be working on. $26 billion in hard cost waste. Take that times 10, in second order waste effect. And we're on the right path here, and technology's booming, healthcare is changing, right place, right time. This is great. You just passed the Y2K. We all lived through it. This is great. And then you think about technology over just since 2000 to now. Some of the things that we've came across here. So Facebook, 2004. Twitter in 2006. The iPhone was just 2007. It's like generation 5S now. Android 2008, being a good competitor now in that market. And the iPad, only 2010. I swear that people have been asking me to have iPads at work more than 3 years. Guaranteed that there's some date wrong there because the requests are still coming. So you think these advancements in technology, moving more mobile, these social media, the way that data is exchanged from anywhere, from remote areas, as long as you can get a cell phone signal, you can tweet. And some people should and some people shouldn't, and there's some entertaining things out there for that. But all this advancement in technology, the access to data, the mission that we have in healthcare to try to improve that and use it, this is the sweet spot, right? This is all going to come together. So what happened? So it's not as easy with healthcare. We talked a little bit about the complexities of it. Some of the things that Mary was just talking about too is the investment. Are we getting the value out of the IT that we're spending? Is it slowing things down? Is change being done in a safe manner? These are real things that we got to worry about. And then if you stop and think, all that advancement in technology, all the talk about we need to use technology in healthcare to improve, and we have. There's been lots of new interventions, new technologies that are brought forth over this time period. But really, when it comes to adoption of technology across the industry, we look at some standards that the Health Information Management System Society collects. And I know it's hard to see on the screen there, but I'll walk you through it a little bit. This is their electronic medical record adoption model. And it rates hospitals on the left and ambulatory on the right, and adoption of EMR technology. This is this year's data, Q3. So at stage 7, which is the highest level adoption on the hospital side, 2.2% of the health systems. The N was around, it says 5,400 and some. So out of that many hospitals, 2.2%. On the ambulatory side, 1.16%, and that's out of about 20,000 ambulatory locations. And if you look at it, when we think about the adoption of the EMR technology, this is the baseline. It's digitizing. It's getting rid of the pen. It's getting rid of the paper. It's finding places in databases to store discrete data, big long strings of text data. It's just digitizing the industry. It's not saying you got to do it good. It's just saying, did you do it? And that's kind of what we're measuring today is, stage 7, you come in. We actually at the University of Missouri Health System on the in the hospital side, we're stage 7. Ambulatory side, we're stage 6. I think we're well on our way to stage 7. They come in and they look. They pull up in a chart. Do you guys depend on paper? No, it's not. It's in the system. Is it in there good? Is it easy for our physicians to put it in there? Are they getting the value out of it? No, not yet. But the promise is still there. And I'd say that really with the way that the industry is going, the change that we're going, this is really just your entry level, and there's only 2% on the hospital side and 1%. Now, it is moving. The High-Tech Act is making people go down this model, but there's costs, there's problems there. Not everyone's going to be able to get there. But this is the baseline, and we're not there as an industry. So we can talk about everything that's happened since then. To get a lot of the value of the data and to be able to spread it across, you got to have people that can submit the data. Something has to be electronic. So that's one thing of concern to think about was where we are right now. And I think this is really rolling out over this decade, a lot of the foundational changes. So there's going to be some rapid adoption that's going to occur, and it's going to be hard. And we went through rapid adoption at the University of Missouri, and it's very hard to move quick and do it in an organized manner. So what is information technology? If you think about the old quote, give me a lever long enough and a place to stand, I'll move the world. So what is technology? How can it change it? Technology is just a lever. It's a big lever. It's something that health systems providers can use to pull to increase their quality, to drive down their cost. And you can see something they can use to compete in this new market to take on more risk. It's definitely available to do that. And as we've talked about in earlier presentations, the pressure's there to use it. You're going to need to do it. You're going to need to pull the lever. You got to be in a position to get there. So we're still not there yet. Some of the things that we're doing in Columbia and mid-Missouri through the university is on our providers. We're at the stage 7, almost stage 7 from the adoption. So at the top level of coolness with EMR adoption, lack of paper, no pens. But as I mentioned, it's not elegant. There's a lot of improvements that we can do. What we're looking on for our providers is they're going to be more mobile. So we mentioned that the iPad, 3 years old, we should already have everything developed on it. We're piloting some of that stuff now. So accessing the EMR through an iPad on your iPhone mobily, remotely. So you can do that now with the electronic charts. They need to be connected, as Mary was talking about. They need to be connected to other providers across the state, across the nation. Really the data share of getting the data at the right place at the right time should be a commodity. It should just happen, It needs to be specialized. It needs to know who they are, what's their specialty. It needs to be specialized to them, too. How do they practice medicine? Make it easy to use. You didn't spend a lot of time learning how to play Candy Crush on your iPhone. It kind of just happens. Now, I'm not going to say that that's as easy as doing, practicing medicine electronically, but still, we have some work to do in that area. And then a lot of what we've done, too, is we've went through and digitized, got rid of the pen, but our electronic systems look like the paper that we replaced. We just took it and put it on a screen and said, look, it's digital. And that's really cool and great, but you got to think about what the technology can do for you. What things do you not need to do because it's electronic? How can it look differently? How can you serve up the information? One of the things about getting that database in the background is if everything's electronic, everything's digitized, it all has its place, then you can begin to put different views together and different skins and ways to access it and interact with it. And that's when you can really do some cool stuff. And then clinical decision support for our providers. So being able to, at the time that they're practicing medicine, provide those decision support tools for them. Those are some of the things that we're doing in the area of providers. Talked a lot about population health. Definitely an area of focus. You heard Stephen talk about a lot of the lower cost clinical integration across multiple different health systems. You're not going to be able to go and buy up every health system and get everyone on the same EMR to do some of these things that you're going to need to do to manage a population. If you're doing a narrow network from an employer, you're not going to do a narrow network for just your little area and expect that everyone's going to travel through your providers. No, it's not going to happen. You're going to have to figure out how to do partnerships and how to use data across the areas. Continuum of care needs to go to post-acute centers. We need to start looking at how wellness and living. So as you start to take on the risk, all those things bundle in, and technology has a place to play in that. One of the things that we're working on is we want a CMS innovation grant at the university, and we call it Light Squared. It's leveraging information technology to provide high-tech, high-touch care. And really, it's been a good discussion point. So it's a 3-year grant. Now we're in year 1 on. We built some tools. We were able to hire new healthcare personnel to act, as earlier as Susan mentioned in her presentation, to take some of the coordination off the physician. We have the tools for them to organize their work. That was some of the high-tech part. And interaction, build tools for the patients that are in this model so that they can view and participate in their care. But really, it's the change. So the technology, the scary thing is technology is usually the easy part. It's the change on adoption and really being able to transform the model. And the thing that I like now is we're going through this. We've in year 1 of the grant, we've rolled out the tools. We have the people hired. They're in doing their jobs, and they're having the conversations on something isn't working. How are we going to do this? And that's exactly what you need to do. You need to try to figure out the conversation and how to move forward as an organization, and you can keep tweaking the tools as you go. So a lot of focus yet to come on managing the health and care populations. Intelligence, and this was talked about as in the big data presentation that Steve gave, and it's very important to us too. We have a lot of data in the charts, historic data. A lot of data is feeding in there from all the machines and all over the hospitals, from the documentation that's being done. A lot of data about our patients are in there, historic data. We're working on building predictive algorithms. And one of the things that we have done in the past year was we introduced what was called the St. John Sepsis Agent. And it sets on cloud data, utilizes the Hadoop technology, so I raised my hand on that. But what it is it's a predictive algorithm. So it'll go through without having to have a programmer go now, where do you store your temperature in your EMR? What field is that? Oh, you have more than one? That's going to take, you don't really have it defined? You don't have this long program. You're able to use that technology, normalize the data, have it run. So it uses crawlers. Some of those technologies like Facebook, Google searches, the indexes, those things bring it up into the cloud. It's up there running all the time, normalized, and you can have these algorithms running full time. So someone comes into our ER and they start to display the signs that this fancy little algorithm says that indicate early onset sepsis. Boom, a light on the tracking board is going to go off. Say, you need to start thinking early about sepsis. You got like 6 hours to really catch that early, so the earlier that you can do it. Second order effect, we had to move up the documentation. Couldn't have people writing down vitals on a piece of paper and going and setting down and entering at the end of shift if we really wanted this to work. So you look at mobile loading of vitals. So load them wirelessly, use the machine to do it, load it wirelessly, have it document automatically, so we can increase that. What we've found in that in the last year, and there was other improvement on this as well, but the incidence of sepsis in our health system that we documented went up by 3%, but our mortality went down by 5%. So we're about 11% below the national average. You start thinking about it early, you have earlier time to intervene. I mean, this is really cool stuff. And it's just scratching the surface of it, really the first runs at it. The other promising thing is research. What different predictive algorithms can we create based on all the data that we have? De-identified data that you can use, that we've captured, that you can use for research. So it's a gold mine. The other area we're focusing on is the patient and the member. And we like to say who has the most say in their health status, and it's the patient. I love that, the questionnaire, the 13 question of how engaged they are. We think about it is the health system, they have a system. Providers usually have a system. Employers, they have a system. If they're in payers, they have a system. Who doesn't have a system is the patient. So what can we do about that? We really want to focus on that, engagement. We're building out our patient portal so that we can leverage future technologies. I have a picture up there of kind of my homepage on it, but we're doing online scheduling now, really early on and trying to move down this path. But we're looking at video visits. We'd like to have that come up and running in the next couple of quarters so that you could use the portal to schedule and launch a video visit through your iPhone, through your smartphone, anything with a camera on it, computer, iPad. Lower cost devices that all you need is connection to the internet. Some people would have them at work. You wouldn't have to go and schedule and travel to do those things. So those are the types of things. We want to embed wellness in there, health risk assessments, communicate. We have, as part of our Light Squared, the provider can set goals, have it flow into the patient's portal, and they can track their progress on it. They can see, I sent you the smoking cessation program online, and I can monitor if you've completed it. So you come in the next visit, did you complete that? Those type of things and the remote monitoring that was discussed. There's a lot more that we can build for our patients, so that's a huge focus for us. And that is all that I had. Thank you.
Hi, good afternoon. I know I'm the last speaker, so I'll try to keep you really excited about mHealth. And so this is the only presentation today besides when Stanford wanted you to get your mobile device out. I want you to get these out, okay? And you're going to have a task to do, sort of in the middle of my presentation.
What's the one on the table?
F. Okay. Okay. So we're going to talk a little bit about mHealth. Has anyone here heard of mHealth? Yeah? Is it different than eHealth? Is it different than A, B, C, D? We don't know what mHealth is. So I was looking around at different definitions of mHealth, and this is the one that I found yesterday, thanks to Dr. Edison sending me a new article from JAMA. It's the use of mobile telecommunications technologies for two things. One is the delivery of healthcare, and two, in support of wellness. So we keep hearing that theme today about the delivery of healthcare as well as wellness. And they sort of put the onus of the healthcare delivery on the provider side and the wellness on the patient side. And I think that's kind of what we're talking about today. So the reason why mHealth is growing so much right now is because a lot of people have phones. In fact, 91% of adults in the U.S. have a phone. And 56% of those are using a smartphone rather than just a phone that does a phone. So who has a smartphone? That's more, that looks like more than 56% in here. So smartphones will allow you to do some of the additional things that we'll talk about in just a second. In addition to that, the digital divide is much smaller for phones than it is on the internet. So because so many people have phones that can get to the internet, they no longer need the more expensive computer and service into their home. And on a larger scale, especially in other countries, mobile technology is much cheaper to roll out. Mobile phones, if you think about it, they're not they don't have the same type of prejudices. So men and women both use phones at the same rate, about 100%, right? Rural and urban people also all use phones, and the young and the old. So in an article that I read recently, Dr. Sebelius listed 3 forces driving the growth of mHealth, and one is the number one thing that everyone has been talking about today, which is the unsustainable cost of healthcare. And the graph on this page is probably the same one that you've seen in other places today. The second force is the growth of wireless, and I know probably most people in this room have seen those commercials on TV for Singular or Mobile T. They show their map compared to others' maps, and they're covering the whole country, and so is everyone else. So the fact that there is wireless virtually everywhere in this country, except maybe in the Ozark Mountains where I'm from, will help you use your mHealth. And then Dr. Sebelius also lists the need for individualized medicine, and that might go back to what other people were talking about, of people taking charge of their own health care. So some of the different ways that mHealth can be used, or some of the different types of applications, the research that I did really put mHealth applications into 4 different buckets. First is measurement, and then diagnostic, treatment, and then sort of global or comprehensive uses. So under measurement, you can download apps right now if you go to your app store that will measure how much exercise you do. It will measure how much sleep. It will measure for you what mood you're in. You have a Fitbit that's measuring you every second of every day. The diagnostic apps will use algorithms to help providers make decisions about what those measurements are. Treatment applications would, for people with chronic diseases, will look at your health outcomes and different items and help you make choices and try to improve your disease management. And then some of the different comprehensive use for applications in mHealth are dissemination of health information. And you can imagine the power of being able to get information out to everyone at the same time, maybe without crashing the system, hopefully, or any system. Disease surveillance looks to be a very big utilization of mHealth as well. So I wanted to just talk to you about a couple of the consumer-focused application. The first one is Nexercise. So I've got some women in my office that use this app, and you can go to your app store right now and look at it. It's a free app. It will help you track your exercise using a GPS system. It uses a support system, so if you know other people that are using Nexercise, then you can log them on there, and then you can nudge them to go do their exercise if they haven't done their exercise today, or you can tell them how much exercise you did that day to try to get them to do more exercise. It allows you to win points that translate into real money on the internet. You can go to Amazon and buy things with the money that you win. It works. Really motivates people. Yeah. Nexercise. Go try it. The next one is called Fujicate. That is like educate and food. So it'll scan barcodes and get nutrition information, and it'll assign grades to that food. So my coworker Mirna Besovic, I showed this to her yesterday, and she and her husband spent the whole night going through their cupboards, finding out if they had any D's or F's, and they did have a couple. This app will also suggest better alternatives to some of the things. So if you are in the grocery store, and I'm telling you, I have a 5-year-old that I'm going to have her take this when we go down the cereal aisle of the grocery store, because I know she won't want those bad grades. So we'll try to find some better choices. On the provider side, there are a few different types of apps here. There are the clinical reference apps that are really internet-based databases that are just translated into use for your smartphone. There are new diagnostic apps. This is the space where you might have heard recently that the FDA will start regulating some of these mobile apps, and these are the ones that they're going to be regulating. So if there is a medical device that will be attached to your smartphone that will take your blood pressure, that is going to have to be FDA approved. Or if the app itself is helping make any decision about treatment. So that picture on the lower right-hand side is a screenshot of the mobile MIM app. Oh, I'm sorry, no, it's not. It's the Airstrip app, the cardiology app for EKG. So you can see that doctors will be able to use their smartphones to actually care for patients where they are with these apps. The public health apps I kind of mentioned earlier, but some of the ones that, for example, the American Cancer Association are putting out cigarette calculators, target heart rate calculators for people to either, reduce smoking or exercise more and figure out what their target heart rate should be. There are telehealth apps. We've been doing telehealth at the university for a long time in many different modalities, including earlier was mentioned the ECHO project in New Mexico. We do something very similar to that project. But we also developed an app here at MU that I'm going to talk about in just a second, and it's really in a different category that is an app specifically to help providers with telemedicine. It's kind of a funny thing. And then, in addition to all these other ones, there are disease management apps. So if you have a specific condition, there are apps out there to help manage your disease that you can get on and log on to. It will help you get into groups of other people with that same condition so that you can get support from them and find out how things are going with them. So just a little bit about the app that we developed here at the University of Missouri. It's called the Telehealth app. And Mirna Besovic, sitting right over here, can you raise your hand? She's instrumental in developing this app, and there are lots of groups involved. So the Immunoinformatics Institute, Computer Science, Department of Dermatology, Health Management and Informatics. Was that everybody? Okay. So in our teledermatology clinic, I have Dr. Dyer here on the right photo, and he's our pediatric dermatologist that sees patients every week over telehealth. On the left picture is a mom and a child that would be seeing a dermatologist. So in the past, what we used was a digital camera that connected through the video conferencing equipment to take pictures. There are a lot of issues with that method around efficiency and quality of the images. And so with the proliferation of mobile devices, that we decided to, actually, it was a professor in Informatics Institute, thought of a way to take images and then have them directly deposited into the dermatology image database, DID. And so now that we are using the TeleMDid app, and we started in 10 locations around the state, and over the summer, we piloted the project and we did pre and post surveys of both the providers and the telehealth presenters. And it turns out that it did improve quality, it improved efficiency of for both the provider side and the patient side. And so we're looking at improving that app and pushing it out to all of our telehealth sites. So while mHealth is pretty new, there have already been some research done around mHealth, especially in other countries. So a lot of these, I sort of just put a long laundry list of some of the research outcomes, but remember, so much of this is also called for the need for additional research. But you can see that on the whole list here, mHealth is effective chronic disease management, effective self-management of disease and clinical outcomes, better quality of life, more reduction of error. You can see the potential here for how we should be looking more at mHealth for some of the things going forward. So I think this is my last slide, but just to kind of show you what some of the challenges of mHealth are. The current reimbursement structure, as people talked about all day, is definitely a barrier to mHealth going forward. Some of the physician concerns around mHealth are reducing face-to-face interaction. They want to make sure that they can still develop a patient relationship. Also, increased workload. Does doing health over their iPhone or their iPad mean that they're going to have to work 24/7? Maybe. I don't know. Other challenges are around security and privacy, and we've talked about that a little bit today. Also, under-regulation or over-regulation, both of those are meaningful challenges when you think about what could happen. Is every single app needing to be regulated by the FDA, when to date there are 90 apps approved by the FDA? So, and there are 100,000 apps out there. Might take a while. Yes. Are the apps that are being developed safe? We don't know. I mean, will they really give people misinformation about their disease or condition or advise them against what a medical doctor would tell them to do? And finally, there's the last challenge I have listed is Big Brother. So I have a Dilbert cartoon where the boss says, "Wear this biosensor so management can monitor your health during the day." And Dilbert says, "Wow, I didn't know you cared so much about my health." "Oh, I do," said the boss. And then you see the little computer guy saying, "Employee 479 doesn't have shallow breathing, so you can give him more work." I know. The potential of mHealth, like I said, there are over 100,000 apps on the market today. Lots of health and wellness apps are leading the way to more adoption, including Lose It and Fitbit, and I know you use Fitbit too. Lots of people maybe use the Fitbit here. Healthcare does move out of the doctor's office and to where the patient is and has the potential of improving health, increasing access while decreasing cost. That's all I've got. Thanks.
I just have two quick comments. One of them is in dermatology in my field, there's about 10 companies now who will advertise that you take a picture of your mole and you send it to them. They'll tell you if it's melanoma or not. And I can tell you that as far as I know, only one of those companies actually has a dermatologist working with them. So I don't know who's looking at these moles. So be careful with that. And the dermatologists won't reveal themselves. They're out of Canada, but they're anonymous. And so it's our field, it's really hot right now. What is safe? And so your safety comment, I think, is a good one. And then I'll also say, I think it's a third of the population knows they have high blood pressure. It's really high. And I'm just waiting and waiting for the app that comes out that can, and they have it, it's just not quite yet, that we can real time monitor our blood pressure. I'm thinking this is going to have a huge impact on the workplace because if in real time you can see what your job is doing to your blood pressure, you might take more walks. You might go on more walking meetings. You might do more mindfulness-based stress reduction. You might actually take your lunch instead of eating it at your computer. So I think that's going to be really, really interesting. I just can't wait. So I think we have a few moments for questions. Remember, if you trickle out, please fill out your evaluations before you leave. But let's have some questions for our excellent panelists. Oh, I'm sorry, Lori Johnson. May I ask you to just say a word, what you said to me at breakfast, because I think it's relevant to this discussion.
I'm Lori Johnson, and I work for University Physicians, and I actually submit most of the quality data that is either voluntary or mandatory because of regulatory compliance. And so I'm down in the weeds of the data and meaningful use and making meaningful use. And my worries, the thing that keeps me up at night is I am all for using data to improve health of patients and the portability and transparency of that data with our patients. But when does the patient get to say, you can use my data? Who can see my data? There are very protected classes of data: mental health, sexually transmitted infections, hepatitis, HIV testing. And so when you think about extracting data from an EMR, you don't necessarily have on that result, is there a release of information for that specific result? I mean, you can set up your system so that it sends all kinds of data, but you have to be careful about what is being sent and what's being sent automatically, especially when you consider a provider's note. There's a lot of information in a provider's note, and it's not necessarily structured, the entire note, although it may come from structured data. So you don't know what's contained in there if you start transmitting notes. And getting the patient's permission to use their data, there also comes into play who paid for the care, who paid for the visit that data resulted from. So a patient may choose to pay out of pocket. So who's entitled to that data? Is the payer entitled to data that they didn't pay for, the care that resulted in that data? It's something we consider a lot when we think about our patients' privacy and protecting it.
Thank you for that. Yeah, one of our challenges is in this last iteration of the HIPAA regulations, we have to be very careful when people come to us for cosmetic things. We cannot send that to the insurer if the patient paid for it out of their pocket. And so our systems have to change as we adjust to these various regulatory programs. And we hope that the regulatory programs are in concert. They're not always. Sometimes there's conflicting goals. So Do you want to say anything about the opt-in, opt-out issue?
I'd be happy to.
Okay.
Listening to you, Laura, that has been one of the big challenges for Missouri Health Connection, and tagging along with what you just said about the harmonization of the regulations. For us, much of the care in our state is on the edges of our state. So patients go across the line and they're in another state, and the regulations around their data are entirely different. So there's really a need across our entire country to harmonize those regulations, and I believe to give patients more control of every single piece of data about them.
I had a quick question. I'm Stan Hudson. I'm with the center here and do a lot around health literacy. And so when it comes to EMRs and EHRs, I know, one of the big challenges is with these patient portals and how, at least in my own patient portal, when I look at it, a lot of that information has been ported over directly from the medical record. It's written by doctors, for doctors, and there's kind of this balance between what doctors need to put in there with the specificity and the language that they need and the jargon they need versus what the patient's going to need and be able to understand and process. And I was wondering if there are any good strategies emerging on how to do that sort of translation.
There's probably a lot of different ways to go about it, but I think the underlying principle is that having the data transparent to our patients is going to really change how we document. There's a lot of things when we have these discussions on what's viewable in the portal. We've had patients call in and say, I don't like to see this problem there. And trying to go through and explain, what that's for. You need to talk to your provider about it. There are those challenges, and you have to weigh kind of what's in the best interests. A lot of people would call in and say, I don't want to see obese on there. And different things like that. There's all kinds of things discussions that we get into that are real problems that you got to kind of struggle with. But the underlying principle of it is those are discussions we got to have, and you got to kind of get through it. And the literacy piece is definitely a part of that, and being able to simplify is there common terms that we can use and leverage, and that's definitely things that we're constantly working with.
And I always say, and why do we say erythema when we mean red? Why do we say xerosis when we mean dry? Why do we use Latin words? Why do we tell patients they have necrobosis lipoidica diabeticorum and pityriasis lichenoides chronica? And, we're going to have to change the words we use. And when I've lectured to dermatologists about this, they always frown at me. It's really fun to start talking about this. And I'm like, we're going to have to change what we call things. We're just, it's going to have to, and people just kind of frown at me and they say, well, no, we have to have someone, translate. I'm like, well, not so much. Patients need to be able to understand what we're talking about. And I worry about the problem list issue too. When I started thinking about the patient portal, I started looking more closely at these problem lists, just, as I was seeing patients and thinking, gosh, I don't know, because a lot of the problem lists have a lot of things on there that people may not want going all over the place, and so it's an issue. And then also, what if something in your chart is wrong? How easy is it to fix it?
And that's one of the things from patient engagement, and it happens all the time. I've used my portal to communicate with my provider or my son's provider and say, this med that you have on there is no longer right. They'll send me back a message, it's corrected. I would have never known. So that's, the other side is transparency, seeing what's in your data, and it's how you react to it. And you can kind of go into the whole discussion on a person's involvement and management of their care. What do we need to hear? Are we going to please everybody? Or, there's a lot of discussions.
And my chart says I'm 5'8", and I'm not. And I don't know if I want to change it because I'd like to be 5'8". Okay, any other questions? Joy?
Thank you. I just wanted to bring the physician perspective here. Looking at our day, most of our day is supposed to be seeing patients and trying to communicate with them, making that connection, etc. And as excited as I am about all these technologies coming, I really want to point out it's not flowing together. The song is not there. There's a lot of noise right now. Those bits and pieces are there, but they're not lining up yet. and the onus of responsibility has been put on the physician. Apart from seeing the patient in the same clinic visit, you have to put in all the orders. When does the patient come back? There are 10 different refills. They want a work excuse. All these things have to be processed by the physician. And the EMRs are not necessarily working at the speed that we would like them to work. So there's a lot of scope. I've been involved in Light Square. It's beautiful, but it's not working as much I would like it to. If my mind's working as a fighter jet speed, I'm still working with a bullock cart, to translate and to cover that distance. So there's lots of scope, but I appreciate the enthusiasm and the optimism. I have personally seen a lot of improvement, but I think a lot more physician input has to go into the way we're designing the EMR, because it has to work for us.
Yeah, so, and that's exactly what I was saying too, is, I think that we've just got rid of the pen. We haven't really done workflows. We haven't really got a smooth process, but the way to kind of make progress on that is you have the data digitized, you can start to do different things with it. And I absolutely agree 100%. I think that's the great thing about Light Squared is we need to have some of these discussions on changing how we deliver care and how does technology fit into that, and see what ways they can work together. And I think the other thing that we need to focus on with a program like Light Squared and really across the board is our clinicians, our physicians are the most expensive piece of equipment that we have in the room. They need to be doing the appropriate things. So you need to look at all the tasks that we're doing and what's in the scope of the license that you can do. And you got to look at the regulations, but what's in the scope of the license that you can do. Take that and put it off of their plate. And then take what you absolutely need to do, and that's what you need to streamline. But right now we've just got it all online. We haven't really dug into that other part, and that's kind of where I'm seeing we need to go.
Sure.
I'd like to share something similar. We deployed our CareMail, which is basically just email, secure email, into some nursing homes. And we went in with great gusto and deployed it, and they all were, their eyes were glazed over, and we had to wait for a little bit, go back, and then help them incorporate that into their workflow. So even something as simple as email has to be incorporated into the workflow. It's a long process. We really are just beginning.
And I would say, for me, the MDID technology helped me do telemedicine so much. See, that was almost like a technology that came out of a clinical need. It's sort of like opposite from, here's the technology, let's make it fit your clinical workflow. This was, I have little kids who are moving around. I have, the lady who was using the cameras on vacation or sick in this little town, and I can't get a good view. So they take high-quality digital photos with the little mini iPads now before I see the patient. So I'm even seeing the skin before I go in to see the patient. I've already got an idea in my head what's going on. It's so much more efficient. It's so much better quality, and patients are happy with it too. And then once we do that, it automatically deletes from the mini iPad that they have, so there's no privacy issues with it. It's just like, you'd see a patient in person. And so it's really better quality of care, more efficiency. So that, I think if we can use technology to solve clinical problems, if it can come up organically from clinical problems, I think that's a real winner, if you will.
And if I may, my only request would be add the busiest of physicians onto your panel. And if the EMR is working for them, then you're making progress. So please take in a lot more input from the busiest physicians. Thanks.
All right. Any more questions before we close? Okay, I want to thank you all for your attention. Let's give the panelists a final round of applause. I want to make sure I thank everyone from the Center for Health Policy who helped with this program, and I especially want to thank Lindsay Beckman and Shirley Walters from the CME office in the School of Medicine. Is Lindsay in the room? No. Okay, well, Lindsay, if you see Lindsay out there, she's got blonde hair, and Lindsay Beckman, she's just worked all year long to make this summit a success. So please thank her, and please fill out your evaluations and enjoy your weekend. Go Tigers.